So I would like to invite the next speaker. The next speaker will be Dr. Ismazizi Zaharudin. Is currently working at the Institute Jangdong Negara from Malaysia, and he's a vascular surgeon. And today he's going to discuss about this expert consensus for treatment of the LT arch lesion. Yeah, doctor, please.
Okay, thanks, Mr. Jefferson, and thanks for Medtronic, and good morning, everyone. Today, I think it's a bit challenging for me to give this talk because I'm talking among the experts. So I think response from the audience and also two previous speakers just like facilitate my talks today. So I got nothing to disclose. Basically, a big introduction. This is where I'm from, the center of Malaysia. That's a small picture. Is my center, who actually is a cardiac center. Now we're starting offering vascular services. These are basically a team of me, consisting of a vascular cardiac surgeon and also interventional cardiologist, which is we work in tandem. But majority of work is actually done by the vascular teams. So a brief introduction in terms of the my talk today is we talk about the arch pathology is either can be the aneurysm or dissections. And study have shown that 60% aortic aneurysms occur in the root and ascendings, and 40% in the descending thoracic aneurysm, and 10 are involving in the arch, which is give more problem to us. And sometimes it involves more than one segment. So why so important was this expert consensus? Because I think we come from the various region, various center have a various approach in terms of how we're dealing with these problems. So basically this expert consensus will covering all aspects of aortic diseases, and we need to understand the natural history of the various diseases process, and to aid and also the indicating the treatment. Most important thing is need to provide the support in choosing the right treatment modalities. Because if from the various center, we will think that maybe our treatment is the best. So I think this will aid us into the find a good pathway in terms of treating and get the good outcome in terms of the patient care. In terms of the type of aortic arch diseases, I think arch aneurysm, as mentioned earlier, is one of the main culprit, followed by the arch dissection, either type A, B, or non-A or non-B, aortic intramural hematoma, and also penetrating aortic ulcer. So when we talk about the dealing with the arch, so what are the challenges that we have in dealing with this arch? Basically, complexity of the anatomy is one of the main issue, especially we're dealing with the bovine arch. And as we know, the potential risk and complication is more compared with dealing with the descending and other region of the aorta, which is a stroke and spinal cord ischemia. And we know as a prolonged hospital stay is one of the main issue, especially when dealing with the open repair. And as we know, these need a specialized treatment approach, especially involving a multidisciplinary team, either for both and open and interventions. We're talking about in terms of the dealing with the endovascular, what are the so unique with the arch, because as we know, as closer to the heart, the pressure and also migration force is higher, and there is a presence of the coronary arteries that lead to very carefully, if not we might lead to a bigger issue when we're dealing with the endovascular. And we have to deal with not only with the coronary, we have aortic valve, and also sometimes we have to working in the LV. And at the same time, imaging will give us some difficulty, especially looking into the best axis to get the good images. And need overdrive pacing for the deployment, and also delivery system challenges. These are the issue, and we're dealing with the endovascular, especially at the arch. In terms of the key principle of management, so I think the most important thing, I think for the vascular surgeon, I think patient risk stratification. But very unfortunate, current available modalities for perioperative risk assessment, like the Society of Thoracic Surgeon Predicted Risk of Mortality and Euroscore 1 and 2, have been well validated for the cardiac surgery, but not for aortic diseases and its surgical endovascular treatment option. So I think as a team, we need to come up with very good risk stratification for our patients. And in terms of a role of surgical and endovascular techniques, so like I mentioned by surgical, two previous speakers, we have either arch replacement, either total hemi-arch, and also elephant trunk, either classical or frozen elephant trunk. when we talk about the endovascular approach, either hybrid procedure or total endovascular repair. And the most important thing is monitoring and follow-ups. For open repair, we know that monitoring intraoperatively and post-operative very crucial. These are the, I think, the thing that I needed to monitor if we are the open operator. And for the endovascular, I think CTA surveillance is very important to detect for endoleak. As the more closer to the heart, I think the chances for the endoleak is higher, and also when dealing with more complex, so the imaging modality will be big issue, and at the same time the lumbar drainage to prevent the spinal cord ischemia. So when we talk about the expert consensus, these are the recent Charing Cross meetings. So sorry about the busy and also a bit small. I think the more important thing when we talk about surgical approach is, I think we involve the massive incisions, very extensive, and also removal of the portion, either complete or partially removed, and to treat the diseases. I think the advantages because of the is suitable for the complex aortic and extensive aortic pathologies, and we get the direct visualizations, and there's no more important is there's no risk of endoleaks. I think the surgical approach has already been explained in detail with the two previous speakers, and also including the endovascular approach. So I won't talk into details about these things. But it's crucial to emphasize that the choice of approach should be made by the multidisciplinary teams and the healthcare professional, and the decision should be tailored to the individual patient condition, taking into account of factors such as extent of the disease, patient overall health, and also their preferences. But the most important thing, whether our center is ready to dealing with these complex aortic arch diseases. For surgical techniques, I think my talk will be facilitated by two previous speakers. I mentioned that Dr. Anshu and also Dr. Titi will give a very good talk in terms of the repair. So these are the options that we have. And then zone 1 and zone 2, so I won't touch into detail. And then these are basically the recommendation that they give for the either elephant trunk and also frozen elephant trunks. So for the hybrid procedures, I've been explained, basically it's just like combination from the both open and endovascular. For the open, basically you will try to get the good sealing zone by doing a debranching procedure, either transthoracic or extrathoracic debranchings. And then these are the recommendations from the consensus in terms of the how we select. And then basically for the debranching option, I think mentioned that it's multiple can be performed by means of anatomical, extra-anatomical revascularizations with the extrathoracic or intrathoracic approach. And for open and vascular procedures, it can be performed simultaneously or staged procedures. It depends on how extensive or how aggressive that we're doing the debranchings. And the main potential advantage if you go for the hybrid approach is avoiding a cross clamp, and if you go for the extrathoracic, I think the extra benefit that we avoid the cardiopulmonary bypass. These are some of the just share with the So these are my patients who are treated with the extrathoracic debranching. You can see the carotid bypass and also transpositions. And these are the images of the patient who are treated with the TIVA and also hybrid procedure. I even go up to the zone 0 for patient with the having the arch pathologies with the debranching combining parallel graft, and these are the follow-up CTAs. And in some of the images, the one that patient who receive treatment. In terms of my experience, these are the initial published paper dealing with the arch aneurysm with a series of the patients who are coming with the arch Horner syndrome. And then these are the number of patients who have been treated with undergoing the hybrid procedure in my center, in National Heart Institute. So in terms of total endovascular repair, so basically we no longer involved in the open debranching approach, but all these things were done through the endovascular. And then if you talk about the total endovascular, I think we need to talk about the fenestrator and the branch endograft who are currently available, which is either as GOTEC and also from the Medtronic, basically a Valiant mono LHA. So these are the recommendations basically that I think the speaker can read to get more understanding in terms of the suggestions. And then, but for me personally, I think I more prefer towards the alternative approach, which is either parallel graph or fenestrations, either PMAC or in situ penetration, because of the custom-made device that takes a longer time to prepare and it's not readily available in my center especially. So these are the some of the just sorry. Okay, these are the patients who are treated with the parallel graph in my centers. So basically, it's TIVA with the chimney at the zone 2. And then in terms of the penetration, so we have an option either in situ penetration, which is a stent graft, and then we use an in vivo creation of the penetration through either needle puncture or laser. And another option, which is PMAC, which is I think usually is been done in the high volume center. This with me and also my team, we did PMAC TIVA, and you can see there is a patient with huge type B dissection with aneurysms, and then so this patient all treated from the groins. So at the end of the procedure, they only have one small incision at the groins, small wound at the groins. These are I think the last. So it can be a single PMAC, single fan, or it can be a double PMAC with double fans. So, ladies and gentlemen, I think these are basically the suggestions from the European Association consensus in terms of how we can choose, and also what are the things that we can guide us in terms of what kind of approach that we can advise our patient when we're dealing this kind of issue, especially at the arch. So, if a patient having a previous coronary bypass with a pattern IMA, and then you can tick on the endovascular, and then poor LV function, right LV functions, I think obviously we'll go for endo, pulmonary functions, poor liver, basically all the comorbid that lead to a prolonged hospital stay and predicting the outcome. And when we talk about the bottom half, basically more towards the access vessel and also the suitability in terms of the anatomy for the TIVA. So I think that's my last slide. Thanks again to the Medtronic and also the organizing committee for inviting me. So these are pictures of me and my teams who are working tirelessly for 2 years to set up the Good Vascular Center in National Heart Institute. But then that's my last slide. Thank you.
Okay. Thank you for your nice talk, and we'll have the discussion later in the group discussion.